Welcome back to The Explainer. When we dive into the complexities of medical billing and compliance, we quickly realize that evaluation and management, or EM coding, is essentially the beating heart of the entire revenue cycle. But there's one specific area that is incredibly easy to misunderstand: split or shared EM visits. Today, we're going to look at how getting this right ensures your practice gets appropriate reimbursement for team-based care, while getting it wrong can lead you straight into an audit.
Okay, let's dive into this. Here's our roadmap for decoding this today. 1. The split visit defined. 2. The substantive portion rule. 3. Identifying the billing provider. 4. Bulletproof documentation. And finally, 5. Modifiers and exclusions. Let's get right to it.
Section 1. The split visit defined. Who, what, and where.
So a split or shared visit is basically an EM encounter in a facility setting that's performed in part by both a physician and a non-physician practitioner. You'll often hear them called an NPP, or a qualified healthcare professional. But pay close attention to the phrasing here, because there are two non-negotiable ingredients. First, it literally has to occur in a facility setting. And second, both providers absolutely must belong to the same group practice. If you don't have both of those boxes checked, well, you aren't looking at a split or shared visit under these rules.
And this brilliantly illustrates what it's all about: collaborative, team-based care. Imagine a physician and a nurse practitioner essentially tag-teaming an encounter to care for a patient in a hospital or ER. They're sharing the workload, right? These guidelines exist to figure out how we accurately report and bill for that joint effort, without double-dipping, but also without undercoding the true complexity of the care they provided together.
Moving right along to Section 2, the Substantive Portion Rule, CPT versus CMS Guidelines.
Now, this is where things get a little tricky, because different rulemakers actually have totally different definitions of what substantive means. Under the CPT guidelines, you get a bit of flexibility. They say the substantive portion can be met by either performing more than half of the total time or by performing a substantive part of a key EM component, like medical decision-making, the history, or the exam. But CMS, for Medicare and Medicaid, CMS has historically leaned way harder into a strict time-based definition. They require greater than 50% of the total face-to-face and non-face-to-face time spent on the visit date. So, in a facility setting, leaning on time is usually your safest and absolute best bet for compliance.
And here is exactly why. Claiming the substantive portion based on medical decision-making, or MDM, carries immense clinical gravity. Just look at the guidelines. The provider must have, quote, made or approved the management plan for the number and complexity of problems addressed, and takes responsibility for that plan with its inherent risk. In other words, the provider billing the service must truly own the clinical risk of that patient's management.
So the crucial point all comes down to a magic number: greater than 50%. When you're relying on the time-based method, which again is highly preferred for compliance under CMS rules, the entire billing decision hinges on exactly this metric: who provided more than half of the combined total time.
Okay, Section 3, identifying the billing provider. Who gets the claim?
Identifying the billing provider actually follows a super logical three-step decision tree. Step 1. You combine the total time spent by both the physician and the NPP on the date of the encounter. And yes, this includes face-to-face time with the patient, plus non-face-to-face time like reviewing records. Step 2. Look at that combined total and identify the provider who performed greater than 50% of that time. Finally, Step 3. Build a claim entirely under that specific provider's NPI. It really is an all-or-nothing assignment based on who crossed that halfway mark.
Now here is where you realize why getting this right matters so much financially to a practice or hospital system. If the physician performs the substantive portion, meaning they hit that greater than 50% mark or carried the substantive MDM, the claim is billed under the physician and reimbursed at 100% of the physician fee schedule. However, if the NPP performs the substantive portion, it gets billed under their NPI, and Medicare will usually reimburse NPP claims at 85% of the fee schedule. That 15% differential? Yeah, that is massive at scale. Accurately tracking who did the bulk of the work is absolutely vital for your revenue.
Which brings us to Section 4, Bulletproof Documentation Requirements, providing the proof. Understanding the rules just isn't enough. If it's not documented perfectly, it's basically an audit trap waiting to happen. Both providers must explicitly document their individual contributions. We're talking independent entry requirements here, meaning the NPP writes the note detailing their time and clinical work, and the physician writes their own distinct note detailing their specific time and medical decision-making. You've got to clearly identify both providers in the record.
And here is the huge trap you have to avoid: attestation-only documentation. A physician literally cannot just sign the bottom of an NPP's note with, "I agree with the above," to claim a split visit. No way. Both professionals have to independently prove their distinct, substantive contributions. All right, last up, Section 5. Modifiers and setting exclusions. Where this applies and where it doesn't.
Whenever you successfully submit a claim for split or shared visit, you've got to append a very specific modifier to the CPT code on the claim, modifier FS. This little two-letter addition tells the payer exactly what happened, that this EM visit was a collaborative effort in a facility setting, and that you've already done the math on the substantive portion behind the scenes.
And speaking of facility settings, there's an improved list where split or shared billing is perfectly legal and super common. You can use this rulebook in the inpatient hospital setting for initial and subsequent care. You can use it in observation units. It's widely applicable in the emergency department when a doc and an advanced practice provider both evaluate the same patient. And yep, it even applies to high acuity critical care scenarios.
But we've got to draw a hard line in the sand right here for you. Split and shared visits are strictly, and I mean strictly, for facility settings. If you're operating in an office or an outpatient clinic, these rules completely go out the window. Instead, you have to rely on entirely different regulations known as incident to billing rules. You definitely don't want to mix these up. Facility equals split or shared, office equals incident to. Keep those buckets separated, make sure both providers document their specific time, accurately track that 50% threshold, and you will have mastered this complex coding challenge.
So, what does this all mean? With so much revenue and compliance risk tied up in what seems like a simple 50% time calculation, you really have to wonder, how many practices are out there unknowingly leaving money on the table, or worse, inviting a massive audit just because of a single missing attestation? Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.